Good night, everyone. I am Sherry Sargent, and tonight I'll be presenting on the pathology of acute respiratory distress syndrome, or ARDS. This is an overview of the objectives that will be covered in the presentation. So, diffuse damage to the alveolar capillary interface is the main cause of acute respiratory distress syndrome. It is often secondary to a variety of disease processes, including sepsis, infection, shock, trauma, aspiration, pancreatitis, disseminated intravascular coagulation, hypersensitivity reactions, and drugs. And treatment includes addressing the underlying cause and ventilation strategies. So, acute respiratory distress syndrome is a manifestation of severe acute lung injury. Acute lung injury is characterized by the abrupt onset of hypoxemia and bilateral pulmonary edema in the absence of cardiac failure or non-cardiogenic pulmonary edema. The major underlying pathology in ARDS is diffuse alveolar damage. So, ARDS, therefore, can be defined as an acute diffuse inflammatory lung injury that leads to increased pulmonary vascular permeability, increased lung weight, and loss of aerated tissue. The pathology identified by alveolar damage with alveolar edema, acute inflammation, and a hyaline membrane formation. ARDS is produced as a consequence of acute lung injury, and this injury to the lung can be direct or indirect. Direct causes can be from pneumonia, which organisms such as Streptococcus pneumoniae, Staphylococcus aureus, Pneumocystis jirovecii, such as in the immunocompromised patients or patients with HIV, SARS-CoV-2, such as in COVID-19 disease, and Mycobacterium tuberculosis, causing miliary tuberculosis. Aspiration pneumonia, where aspiration of gastric contents, the gastric acid and bacteria, leads to injury to the lung parenchyma. Lung contusions, where trauma results in injury to the lung parenchyma. Toxic smoke in the form of oxygen toxicity, smoke, irritant gases, and chemicals, and near drowning, for example, with drowning in seawater, where seawater is hypertonic. When hypertonic solution enters the lung, it pulls fluid from the capillary into the alveoli, and this leads to pulmonary edema. An inefficient gaseous exchange occurs, whereas drowning in fresh water is hypotonic, and hypotonic solution in the lung flushes out the surfactant, and a decreased amount in surfactant causes decreased surface tension in the alveoli, leading to alveolar collapse. Indirect causes of ARDS include systemic conditions where there is massive inflammation or immunogenic reactions, and these cause damage to the capillary endothelium and subsequently the alveolar epithelium. So sepsis is one of the most common causes of ARDS, where infectious pathogens enter the body and it activates the immune system, where the macrophages release cytokines, namely interleukin 1, 6, and tumor necrosis factor alpha, vasodilation and increase in vascular permeability, and 2, damage to the capillary endothelium and alveolar epithelium. Pancreatitis is another common surgical cause where there is release of cytokines, release of pancreatic enzymes, leading to damage to the pancreas causes release of pancreatic enzymes, and both cause capillaries to become leaky due to vasodilation and increased vascular permeability, and damage to the capillary endothelium and alveolar epithelium. Multiple long bone fractures causes fat globules from the medulla to leak out as well, and these are called fat emboli. They get metabolized in the blood into oleic acid and causes damage to the capillary and alveolar epithelium, again causing interstitial edema and pulmonary edema. TRALI, or transfusion-associated lung injury, most commonly seen in transfusions of fresh frozen plasma and cryoprecipitate, where both contain donor antibodies and phospholipids. These activate neutrophils, and the neutrophils sequester in the capillaries. They release cytokines, proteases, and reactive oxygen species, or ROS, and these cause damage to the capillary and alveolar endothelium as well, resulting in interstitial and pulmonary edema. And drugs such as cocaine, opioids, and aspirin toxicity can result in ARDS. So delving into the pathophysiology, the time course for the development and the resolution of ARDS would start from the 0 to 3, where there's the exudative phase, where there's edema, and by day 7, there's the hyaline membrane forming. Then around day 14, there's interstitial inflammation or in the proliferative phase. And by day 21, fibrosis can occur in the fibrotic gene. And we'll go through these phases. So injury to the pneumocytes. So they are the two most common, as we would have went through last week: type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes are simple squamous cells, and type 2 pneumocytes are cuboidal cells. The majority are type 1, accounting for 95%, and 5% type 2. The function of type 1 pneumocytes are for gaseous exchange, while type 2 is for mainly production of surfactant. And the consequence of damage would be no gaseous exchange for type 1 pneumocytes destruction versus alveolar collapse for type 2 pneumocyte damage. And the ability to divide with type 1 is no. So it's amitotic. And type 2 pneumocytes, they can divide because they are from stem cell origin. So injury to the pneumocytes, the etiological agents cause damage to the type 1 and type 2 pneumocytes due to the triggers releasing the cytokines or recognition of particles, and cytokines activated alveolar macrophages. The alveolar macrophages are activated by cytokines and directly by the pathogen, and macrophages then release interleukin 1, 6, 8, and tumor necrosis factor alpha. This leads to leaking into the pulmonary capillaries, and it affects the endothelium by increasing capillary permeability and increased cell adhesion molecules, or CAMs, expression. They activate neutrophils, and then they damage the channels on the type 2 pneumocytes. When there's an increase of fluid in the alveoli, the fluid is taken up by the type 2 pneumocytes by the channels and then expelled from the alveoli. When these channels are damaged, the excess fluid accumulated is not resorbed. So the exudative phase, you have interleukin 1, 6, and tumor necrosis alpha, as I would have mentioned. With increased capillary permeability, the capillaries become more leaky, and fluid from the capillaries leak into the interstitial space. And there's the increased expression of cell adhesion molecules, which allows the recruitment of the neutrophils. Neutrophils squeeze through the vessels to reach the pathogens within the alveoli, and then interleukin 8 causes chemotaxis, which recruits and activates neutrophils. Neutrophils in the alveoli, they enter by the action of interleukin 1, 6, tumor necrosis factor alpha, and interleukin 8. And then there's degranulation of the neutrophils, which release ROS, or reactive oxygen species, proteases, and neutrophil extracellular traps, or nets. And these damage the type 1 and type 2 pneumocytes. There's then damage of the alveolar epithelium. Fluid accumulates in the alveoli. Fluid collected in the interstitium leaks into the alveoli through the damaged epithelium. And then there's formation of the hyaline membrane, where fluid from the interstitium accumulates in the alveoli, and this edematous fluid contains proteins, which also accumulates. Fibrin deposition occurs, and cellular debris collects as type 1 and type 2 pneumocytes are destroyed. White blood cells accumulate as they are recruited, and few red blood cells are collected, and these together form a layer of the alveolar epithelium called what we know as the hyaline membrane. So the hyaline membrane is a collection of edematous fluid, proteins, fibrin, cellular debris, white blood cells, and a few red blood cells as well. So the pathogenesis of the signs and symptoms would start first with hypoxemia. Damage to the type 2 pneumocytes would lead to decrease in surfactant synthesis, and this would then lead to an accumulation of fluid. Fluid accumulating in the alveoli washes away surfactant, so surface tension increases, and it leads to the collapsing pressure to increase as well. Looking at Laplace law, with P being the collapsing pressure and T being the surface tension, R being the radius of the alveoli, P, which is the collapsing pressure, is equals to 2T over R. So when there is an increase in the surface tension, the collapsing pressure increases as it is directly proportional. So consequences of hypoxemia would be cyanosis or the bluish discoloration of the mucous membranes, reflex compensatory mechanisms such as tachypnea, where hypoxemia stimulates the chemoreceptors and this increases the respiration rate, and tachycardia, as this increases perfusion through the pulmonary circulation, and crackles on auscultation because of fluid accumulation in the alveoli. Its increased work of respiration leads to increased respiratory effort. During inspiration, it pops open the alveoli and thus produces the crackling sounds. So the proliferative stage, this is when there's resolution, reepithelialization, which repairs some of the type 1 and type 2 pneumocytes. Type 2 cells proliferate and form the type 1 cells as well, and it leads to formation of granular tissue. This then leads to the removal of fluid from the alveoli, and type 2 pneumocytes resorb the fluid and expel it from the alveoli. The fibrotic phase, or the phase of fibrosis, in some cases, is when the granulation tissue does not resolve and it leads to fibrosis. Macrophages and neutrophils produce platelet-derived growth factor and tissue growth factor beta. These stimulate fibroblasts, and the fibroblasts synthesize thick connective tissue. This causes compression of vessels, and it makes the lung very rigid, and it decreases lung compliance. These contribute to causing restrictive lung diseases. So when we hear about ARDS, we must think about the Berlin's criteria for diagnosis. It includes acute respiratory failure. So that is acute respiratory failure within 1 week of the known predisposing factor, for example, sepsis, and the diagnosis of the initial cause. For example, if sepsis would be made by doing cultures such as blood cultures, sputum, urine analysis. Secondly, bilateral opacities or a whiteout seen on imaging. And imaging of the chest include chest x-rays, CT, lung ultrasound, and this rules out a cardiogenic source. So on the chest x-ray, the indications are for all patients suspected of having ARDS. In the acute findings within 1 to 7 days, it is often normal in the first 24 hours, but then diffuse bilateral symmetrical infiltrates occur. And in severe cases, there may be bilateral attenuations that make the lung white on the X-ray having a white lung, a white out lung. The intermediate is between 8 to 14 days to late, greater than 15 days. The typical course of acute features remain stable, then they resolve, or there's the fibrotic course where reticular opacities begin to appear and some become permanent. So the findings supportive of ARDS rather than congestive heart failure would be predominantly peripheral opacities, small or absent pleural effusions, and no cardiomegaly or septal lines. Thirdly, the partial pressure of oxygen to the fraction of inspired oxygen ratio. So for mild ARDS, this ratio is between 200 to 300. For moderate, it's between 100 to 200. And for severe, it would be less than 100. And for non-cardiogenic pulmonary edema, that is, all cardiogenic causes of respiratory failure must be ruled out. This can be done with the assistance of an echocardiogram where left ventricular ejection fraction should be normal. The beta-natriuretic peptide should be normal as well. This is usually increased in congestive cardiac failure, where heart failure causes volume stress due to which the ventricles would increase BNP. And the pulmonary capillary wedge pressures should be less than 18, and this rules out cardiogenic causes. This can be estimated by a Schwann-Ganz catheter, which is a definitive test. So a mnemonic to remember the Berlin's criteria for ARDS is ARDS, A for abnormal chest X-ray, R for respiratory failure that ensues less than 1 week of clinical course, D decreased PF ratio, and S, it should exclude cardiac congestive failure. So the treatment, this would depend on if ARDS is due to, if it is mild or moderate, and if the patient is hemodynamically stable or non-hemodynamically stable. So for mild ARDS, if a patient is hemodynamically stable, non-invasive positive pressure ventilation is tried. And if there's no improvement on the non-invasive positive pressure ventilation, the patient is subsequently intubated. For hemodynamically unstable patients, patient is intubated. And for moderate to severe ARDS, intubation is done and lung protective ventilation is practiced. So if the PF ratio is less than 150, pruning, neuromuscular blocking agents, inhale nitric oxide, alternative ventilator modes such as APRV and ECMO can be implemented. And if the patient has the COVID virus or additional medications can be added to the regime. So the initial management would be to initiate volume pressure limited ventilation. The goals and limits would be a tidal volume that is less than 6 mils per kilogram per body weight, a plateau pressure of less than 30 centimeters of water, and a respiration rate that is less than or equal to 35 breaths per minute. To oxygenate the patient, the FiO2 should be less than or equal to 0.6, and an SpO2 of 88 to 95% is acceptable in these patients. Minimize acidosis, so a pH of greater than or equal to 7.3 is recommended, and a respiration rate of less than 35 breaths per minute. And for diuresis, MAPs of greater than 65 milligrams Mercury is encouraged to avoid hypoperfusion. So delving into non-invasive positive pressure ventilation, high flow nasal cannula or HFNC can be used to increase the flow rate of oxygen with 50 to 60 liters per minute. This decreases the dead space and it increases the positive end expiratory pressure or PEEP. This is the pressure that keeps the alveoli open after expiration, and the function of it is to reduce the work of breathing and to improve oxygenation. And the FiO2 can be controlled with up to 100%. BiPAP or bilevel positive airway pressure is used if there's atelectasis, where the IPAP and EPAP, IPAP is the inspiratory positive airway pressure. This controls the peak inspiratory pressure during inhalation, and the EPAP is the expiratory positive airway pressure. This controls the expiratory pressure and again controlling the FiO2 up to 100%. So the term to be used here is lung protective ventilation. And the parameters for this would be a tidal volume that is low, and ideal is 4 to 6 cc's per kilogram of ideal body weight. So the tidal volume is the best indicator for mortality, and the consequences of an increased tidal volume is that it causes the volume trauma or barotrauma due to the expansion of the alveoli that's already open, and it increases the plateau pressure. The consequences of a decreased tidal volume would mean decreased air that is inspired. Hence, the person breathes out lesser carbon dioxide, and this causes respiratory acidosis. Sometimes this is preferred, and this is called permissive hypercapnia. So positive end expiratory pressure or PEEP, the goal is to increase the PEEP because we want to keep the alveoli open at the end of expiration. So the PEEP is the pressure at the end of expiration. And the function is that during inspiration, it opens up the collapsed alveoli, and during expiration, it keeps the alveoli open, and this decreases the work of breathing and it augments oxygenation. So increased PEEP would lead to an increase in the oxygen concentration. The goal for the FiO2 would, as mentioned, would be greater than 60% with a SpO2 target of 85 to 95%. And this augments oxygenation, maintenance of pressures, so the plateau pressure or P-plat for measurement of the degree of lung injury. So an increase in the plateau pressure can be caused by a tidal volume, which is most increase in the tidal volume, which is most significant. And the PEEP, when highly increased, raises the PEEP plot as well. And this increased pressure in the alveoli and barotrauma causes lung injury. So when the PEEP plot is greater than or equal to 30 centimeters of water, a lower tidal volume is achieved, and the tidal volume is at minimum than the lower the PEEP. And the driving pressure is the P plateau pressure minus the PEEP. And when the driving pressure is equal to 15 centimeters of water, there is reduced mortality. So other non-ventilator mechanisms would be positioning, such as prone positioning. Proning reduces mortality, and the principle is that the dependent position of the lung is in the posterior lung fields, So in a supine position, the heart presses on the consolidated lung tissue, and this decreases aeration. The prone position, the heart presses anteriorly, so this allows for posterior areas of the lung to become open, and this increases aeration and compliance, and increase oxygen delivery to the blood as well. Other things would include inhaled pulmonary vasodilators, such as nitric oxide or prostaglandin I2 or prostacyclin. They get into the blood of the well-aerated alveoli and then dilate the pulmonary capillaries, and this increases blood flow to well-aerated alveoli, and it improves oxygenation. The use of paralytics is also important. So lung protective ventilation adopts a low tidal volume strategy, and this can cause asynchrony. Due to the decreased oxygen concentration, the patient's body tries to respire, over the ventilator, and this is achieved by sedation with agents such as propofol, midazolam, and opioid boluses, and paralysis of the respiratory muscles. For example, the use of cisatracurium causes neuromuscular blockade, and this makes the patient completely dependent on the ventilator. ECMO, or extracorporeal membrane oxygenation, this is where deoxygenated blood from the inferior vena cava is taken out, and it is passed through the machine or the oximeter, and it oxygenates the blood such that the concentration of oxygen is very high, and the oxygenated blood is pumped back into the body through the superior vena cava. Oxygenated blood thus reaches the heart. So this is a summary of what was done in this presentation. I would just like to share another PowerPoint where I would delve a little bit into an update to the Berling's criteria, as well as to go through some gross and micro and microscopic features of ARDS. So to go through the gross description, along with in a patient with ARDS, it typically has a brown to gray consolidative lesion with indistinct borders, diffusely involving bilateral lobes, and there's an elastic, hard, and greasy appearance due to the transudate within the alveolar spaces and the interstitial edema. Heavy and shrunken due to fibrosis and collapse of the tissue. And you can see as well dots of hemorrhage on the pleural surfaces of the lung tissue. The microscopic or histological description, it would have gone through the different stages of ARDS. So, for example, in during the exudative or acute phase, the alveolar changes that can be noted would be the hyaline membrane on the alveolar ducts or the sacs, interstitial and intra-alveolar edema, collapsed alveoli, and epithelial changes would be the denudation of and necrosis of the type 1 pneumocytes, vascular changes as well, such as necrosis of the endothelial cells, neutrophil aggregation, thromboemboli, and hemorrhage can be noted. In the proliferative or organizing subacute phase, the alveolar changes would include remnants of the hyaline membrane with or without organization, interstitial and intra-alveolar proliferation, of the myofibroblast and lymphocytic infiltration. And we can see it in the slides to the right. The epithelial changes would include proliferation and hyperplasia of the type 2 pneumocytes. Vascular changes would include endothelial injury and the thromboemboli in the arterioles. And in the fibrosis stage, the alveolar changes would be collagenous fibrosis noted, microscopic honeycomb-like change, and traction bronchiolactasis. And the epithelial change would be the squamous metaplasia and hyperplasia. Vascular changes would involve the remodeling of the arteries, the intimal fibrosis, thickening of the media, and others may have superimposed pneumonia or fibrin deposition or diffuse alveolar damage with prominent organization. Pneumonia is also called organizing diffuse alveolar damage. The cytological description, so with a bronchoalveolar lavage fluid, it can show increased neutrophils and ARDS, and this can be helpful for the diagnosis of the underlying disease. And with regard to staining, fiber staining, such as the Elastica Van Gieson, is helpful to evaluate fibrosis and to evaluate the destruction of the alveolar architecture. The Jamsa staining, Grucott, and the Zeal-Nelson stains are helpful as well to identify pathogens. And with regard to immunohistochemistry, which is not of practical utility, but the cytokeratin highlights the collapsed alveoli and lung architecture. And just to go a little bit, in 2024, the global definition expands on the previous Berling's criteria, where it's included in patients that are not intubated. It uses the SpO2 to FiO2 ratio. If the SpO2 is less than 97%, and it gives in the purple on the right lower aspect of the table, it shows that for mild, the SF ratio was adjusted to 235 to 315. Moderate would have been 148 to 235, and severe would have been less than 148. So this brings me to the end of the presentation. Thank you.